And what I am going to do is just to present something all of you know very well, and maybe the most important part will be to try to discuss this data and especially how to position these two new combinations in the future landscape for myeloma. As Mia previously said, the discussion is supported by GSK, and here we can see the treatment landscape in multiple myeloma. And according to the current landscape, you can see how in the first line of therapy, the majority of the patients are going to be treated with PI, needs anti-CD38 monoclonal antibodies. At the moment of the relapse, it's true that we are not going to see basically patients naive for lenalidomide. This was something that we saw in the past. But if this would be the case because of the use of, for example, DARA VMP in some patients in the past, it is possible to select whatever of these Lendex-based combinations at the moment of the relapse. And even if the patient would have been exposed to lenalidomide, but not refractory to lenalidomide, we can see here how the majority of these combinations, especially DARA, Lendex, or KRD, included a subgroup of patients previously exposed to lenalidomide, and the benefit and the hazard ratio for PFS was consistent with the hazard ratio observed in the overall population. But it's true that this is the most realistic situation. And maybe you agree with me that when we have in front of us a myeloma patient relapsing or progressing after the first line of therapy, the selection of the first rescue therapy is basically based on the sensitivity, refractoriness to daratumumab and or lenalidomide. And if the patients are refractory to lenalidomide, that this is going to be the common situation for the majority of the patients, and sensitive to the anti-CD38 monoclonal antibodies, we are going to select KD or Pomdex plus anti-CD38 monoclonal antibodies. You can see here the candor in which you know that DARA KD showed to be superior to KD in terms of progression-free survival. Approximately one-third of the patients were refractory to lenalidomide, and the benefit was sustained. The safety profile was acceptable, but important to note, this study did not report benefit in overall survival. An IKEMA study was similar in design, but the monoclonal antibody anti-CD38 was isatuximab instead of daratumumab. Similar superiority for ISA-KD versus KD with a hazard ratio of 0.58, and again, benefit in the population refractory to lenalidomide with safety profile, but again, no benefit reported in overall survival. And DARA-PD is another possibility evaluated in the Apollo. It's true that the Apollo is different because the majority of the patients had received at least 2 prior lines of therapy, and the majority of the patients were indeed refractory to lenalidomide. This is the reason why the median PFS for DARA-PD from the numerical point of view was lower in comparison with DARA-KD or ISA-KD, but anyway, always superior to the control arm pomalidomide and dexamethasone. And again, Apollo didn't report the benefit in overall survival. And it's true that when patients are refractory to lenalidomide and maybe also refractory to daratumumab, this is the real situation for patients coming from DARA Lendex in the first line of therapy. We have the possibilities you can see here in this square, and I am maybe referring mainly to the non-US countries because maybe you have the possibility of using other novel combinations. I will address them later on, but we can use either PVD, selinexor, bortezomib, and dexamethasone, or just carfilzomib and dexamethasone. And PVD was superior to VD in the Optimism trial, presented several times by Paul Richardson. It's true that all patients were Len exposed, and the majority of the patients were refractory to lenalidomide. The progression-free survival, the median was approximately 11 months, and again, no significant benefit was observed in terms of overall survival. And we have a selinexor, bortezomib, and dexamethasone as another combination in which the control arm was bortezomib and dexamethasone. Selinexor, bortezomib, and dexamethasone was superior with a median progression-free survival of approximately 14 months. This superiority was also observed in the population refractory to lenalidomide. Safety profile, I think that it is acceptable if we know how to manage dose of selinexor, but again, no benefit was reported in overall survival. It's true that this is what we have basically right now, but novel combinations, novel approaches are coming, and the best or the first BCMA targeted therapy incorporated in earlier lines of therapy in myeloma has been filtafel. Filtafel, the BCMA CAR-T, evaluated in the CARTITUDE-4, in which you know that the control arm was PVD or DARA in combination with pomalidomide and dexamethasone. Filtafel demonstrated to be superior in complete response rate as well as minimal residual disease negativity rate in the intent to treat patient population, 60% versus 15.6%. For me, it's more relevant to see the sustained benefit recently reported in terms of both progression-free survival as well as overall survival. And we've seen before how the other combinations have not shown yet benefit in overall survival, but cilta-cel is superior to either dara-VD or dara-VD in terms of overall survival. Safety profile indeed was acceptable. No new safety signal has been reported. Quality of life in CARTITUDE-4 showed a great benefit for the patients with a clear improvement in some domains like pain symptomatology or fatigue, and indeed cilta-cel is approved in relapsed refractory myeloma patients after at least one prior line of therapy, being all of them refractory to lenalidomide. But at the same time, you know that cilta-cel is not available in the majority of the countries. It is available in the US, and in Europe, it is possible to be used, if I am correct, in Germany, in Austria, and in Switzerland. And we are waiting for the approval in other European countries. But we are going to have, as you can see here in this slide, other new approaches, other new T-cell redirecting therapies, and antibody drug conjugated based combinations that will be incorporated to the second line and beyond. So the key question will be how to select the right combination in the near future. We don't have yet any data about the bispecific monoclonal antibodies in this setting, but we have here DREAM7, in which, as you know, Belantamab mafodotin in combination with bortezomib and dexamethasone was compared 1-to-1 with the dara-VD in relapsed refractory myeloma patients after at least one prior line of therapy. Bela-VD and dara-VD were given for 8 cycles, followed by either belamaf single agent or daratumumab single agent. In terms of baseline characteristics of the patients, the median number of prior lines of therapy was 1, and to note that the majority of the patients were previously exposed to bortezomib, half of them were previously exposed to lenalidomide, and 33 and 35 were refractory to lenalidomide. Because of the study design and because of the control arm, you can imagine that basically patients previously exposed to daratumumab were not included in this study. This is the primary endpoint, and apologies because this is not the usual way in which we see the PFS with the Kaplan-Meier curve. So for me, it is easy to go to the table to see how Bela-VD was significantly superior to dara-VD with a median PFS of 36.6 months versus 13.4 months with a hazard ratio for 0.41. And we are going to see how this superiority in PFS was actually observed across all pre-specified subgroup of patients. and in spite of the follow-up is not very long and the overall survival continues ongoing in follow-up, there is a trend to a benefit in overall survival for Bela-VD versus Dara-VD with a hazard ratio of 0.57, and an update of the overall survival benefit will be indeed presented at us as oral communication, and it will be presented by our colleague Vania Hungria. As I previously said, for me it's important to see how the superiority of Bela-VD over Dara-VD was sustained in two tissue group of patients. Point number one, the refractory population to lenalidomide. If we focus on the control arm, we can see how Dara-VD in the len refractory population resulted in a median PFS of 8.6 months, and Dara-VD in the non-len refractory 18 months, so great difference. When we evaluate the same effect in the Bela arm, Bela-VD in the non-len refractory 36.6 and 25 months in the len refractory population. And more or less the same effect is observed in patients with high-risk cytogenetic abnormalities, 33.2 months of median progression-free survival for Bela-VD in high risk and 36.6 in the standard risk, indicating that the addition of Belantamab to VD is going to be able to improve and I would say maybe overcome the poor prognosis of at least some of high-risk cytogenetic abnormalities. In terms of adverse events, you know that thrombocytopenia is the most frequent hematological toxicity observed with Bela-based combination, and indeed it was a bit higher in comparison with Dara-VD. And concerning ocular toxicity, the most frequent adverse event was vision blurred, followed by dry eyes, photophobia, and so on. And indeed, concerning other non-hematological adverse events like even infections or diarrhea, peripheral neuropathy, it was quite consistent in both arms. In terms of ocular toxicity, the most appropriate way to evaluate the ocular toxicity is maybe the changes in the best corrected visual acuity. In the left-hand side of the slide, we can see the normal visual acuity. In the middle, what we can consider blurred vision, and in the right-hand side of the slide, actually the impaired vision with a clear deterioration of the visual acuity. If we evaluate all patients with a visual acuity at baseline 20/25 or better, it is possible to see how 34% of the patients experienced a worsening in the visual acuity to 20/50 or worse, so in the middle, just what we can call the blurred vision, and indeed only 5 patients experienced clear deterioration of the visual acuity to 20/200 or worse. This is relevant, but for me it is more important to see how with those reductions, with those delays, interruptions, all patients recovered from the ocular toxicity, and 9% of the patients had to discontinue because of any ocular event. Here you can see the median time to onset the first event, a bit longer than 2 months. The median time to resolution of first event, approximately 2 months, but you have to know that all patients resolved. This slide is also very interesting. And you can see here in this blue line, the median weeks between doses of Belantamab. And at the beginning, it was planned according to the study design to prescribe Belantamab 2.5 milligrams every 3 weeks. And this is what we see here. But throughout the treatment, the median weeks between those increased. And indeed, you can see how the majority of the patients receive Belantamab every 11 or even every 12 weeks. This didn't impact in the efficacy, and indeed the median progression-free survival was consistent with the median PFS reported in the overall population for those patients with those delays even up to 12 weeks, and this impacted into a clear reduction in the safety profile in the incidence of bilateral deterioration of the visual acuity 2050, or even worse. And this is something that we are going to see in a similar way in the dream age with Belantamab in combination with Pomdex. This slide represents the dose intensity by 6-month time interval, just in order to see how the majority of the patients had to reduce the dose to extend the interval doses, and at the end, the dose intensity the patients received was inferior in comparison with the expected one. And here you can see during the first 6 months, the dose intensity was 1.6, 0.8 in the 6 to 12 months, and beyond the first year, 0.5. And you can see how it is equivalent to 1.9 milligrams per kilo every 6 weeks. We are going to see the same data from Dream H, in which you know that Bela PD was compared with PVD. The study design was a bit different. The dose of Belamab was 2.5 milligrams per kilo IV on cycle 1, and later on the dose was 1.9 milligrams per kilo. Cycles were of 4 weeks. And in terms of baseline characteristics of the patients, the population, I would say that is more similar to the CARTITUDE-4 population. The majority of the patients previously exposed to bortezomib, as in Dream 7, but here all patients were exposed to lenalidomide, and 76% of them were refractory to lenalidomide, and we had here approximately 25% of the patients exposed to daratumumab or anti-CD38 and refractory to the monoclonal antibody. So this is maybe a more realistic population we are going to see today in first relapse. Anyway, in terms of progression-free survival, it was the primary endpoint and a clear benefit for Bela PD over PV. Median PFS not reached, 12.7 for PVD, in line with what we've seen indeed in the Optimus trial, in spite of the fact that in the Optimus patients previously exposed to daratumumab were not included, and the hazard ratio was 0.52, and this superiority was again consistent across the different subgroup of patients, including the population refractory to bortezomib or population with high-risk cytogenetic abnormalities. Here, you can see the benefit also in durability of the response, clear benefit for Bela PD versus PVD, and the clear trend in overall survival benefit also in terms of overall survival, with the median overall survival not reached yet in neither PVD nor PVD arms. In terms of a safety profile, I would say that it is quite similar to what we've seen with Bela PD, although it's true that here Bela PD were given as continuous therapy. This means that there was not any discontinuation for pomalidomide as it was done for bortezomib in the Dream 7, and this means that the incidence of neutropenia, grade 3 neutropenia, was maybe higher than that reported in the other Dream study, with a translation in an 82% of infections, with approximately 49% grade 3 and 4. And this is also observed, of course, in the control arm, because pomalidomide and dexamethasone were taking part also of the combinations. And in terms of ocular events, more or less the same symptomatology we've seen for Dream 7, and in terms of best corrected visual acuity, more or less the same percentage. 34% of the patients experienced a decline of the visual acuity to 20/50, and only 2 patients to 20/200. And again, with those delays and those modifications, all patients resolved, and very few patients had to discontinue because of toxicity. And the same effect over time, the weeks between doses increased, but efficacy was not impacted, and there was a reduction in the incidence of adverse events. And again, when the dose intensity was evaluated, 1.37 during the first 6 months, and beyond the first 6 months, you can see how the average dose intensity is similar to 0.63 milligrams per kilo every 4 weeks, equivalent to 1.9 every 12 weeks. So if we incorporate these two new combinations, Vela-VD, Vela-PD, into the treatment landscape, and we will incorporate in the future teclistamab data, ELRA monotherapy, talquetamab data, teclistamab and talquetamab. So I think that the challenging situation and another important unmet need we have to resolve is the education in order to select the appropriate therapy for each patient. And honestly, we have to consider all these factors. Treatment history is important. I don't know if after bortezomib, lenalidomide, and daratumumab, we are going to move directly to the BCMA targeted therapy, because I understand that some of these patients will be eligible for DARA-KD, ISA-KD, or maybe other POM-based combinations, and I don't know how we are going to proceed. From my point of view today, I think that if I have a young patient, transplant eligible, early relapsing after the first line of therapy, triple class exposed, if I have a cilta-cel available, maybe for me this would be the best choice. But of course, the other possibilities will be feasible. For the main limitation for this approach is the slot availability and even the access to cilta-cel that, as I previously pointed out, in the majority of the European countries, we don't have access to cilta-cel in this situation. The second situation will be the most common population, transplant eligible, but no early relapsing, but late relapsing. This means that these patients can receive whatever of this combination, but we can consider KD plus anti-CD38 monoclonal antibodies as a possibility, and to reserve the BCMA targeted therapy for the third line of therapy. And the transplant ineligible population, those coming from DARA index, we can potentially consider also cilta-cel, but the reality is maybe this elderly population will not be eligible for BCMA CAR-T, and for me this is the population in which I see a more clear role for the Bela-based combination, either with bortezomib, because the patients are going to be naive to proteasome inhibitor, or with pomalidomide, because it's true that DREAM-H reproduced more the population treated and refractory to lenalidomide and even daratumumab. And this is the population again in which I see a more clear role. But we will have, of course, the bispecific monoclonal antibodies, and for me, in the transplant ineligible population, maybe the challenging situation will be to select between bispecific monoclonal antibodies or Belantamab-based combination. We have to wait to know the efficacy and the safety data from the bispecific monoclonal antibodies, and we will have how to proceed. How will the DREAM studies impact clinical practice? These are, of course, personal thoughts. I think that Bela-VD and Bela-PD will come back to the treatment landscape, will be selected, of course, based on patient and disease-based factors. And the major advantages, from my point of view, for these combinations are off-the-shelf drugs, no pre-medication required, no hospitalization required. The partners are indeed generic. The keratopathy is manageable after the learning process. The BCMA loss seems not to be a mechanism of resistance, and the T-cell fitness is going to be maintained. And I think that this is my last slide. Well, this is again how to select. And well, we can proceed to the most interesting part, that it is the discussion about these combinations. Of course, not only the Bela-based combination, but how we will approach to the management of early relapse in the future when all these combinations are available.
Yeah.
And you can start, of course.
So, Mary, that was lovely and very informative. I just one question, because I was looking at some of the CARTITUDE data that was coming out about prior antibody drug conjugate exposure and then response to CAR-T. And in the data that they reported, they described a fall off in the antibody drug conjugate exposed patients in terms of efficacy. And I'm struggling with that one to better understand it, because I agree with you. From my own real world experience, has been Bela exposure has not necessarily penalized patients later in terms of their response. So I just wondered what you thought about that, because I think I'll give you a real world example. I have a younger patient who we'd actually deferred on transplant many years ago, did very well. I offered him CAR T, he refused, and he's now in CR and 3 years into his Bella program without any sort of, well, actually, sorry, I apologize, 2 years into his Bella program now, doing well. And I'm thinking still of CAR T later for him, but that's just an anecdotal experience.
Yeah.
But I'm just wondering what your sense is of that.
Well, I think that the only data we have are coming from a cohort of the CAR-T2, in which the patients previously exposed to BCMA-targeted therapy received cilta-cel. This paper was published in Blood. The first author is Adam Cohen. And if you remember, the efficacy with cilta-cel after BCMA bispecific monoclonal antibodies was very poor. And indeed, the median progression-free survival was approximately 4 months. When these data were updated, the efficacy of cilta-cel after antibody drug conjugated improved. And if I remember well, I think that it was almost 10 months. But we have to consider, Paul, that these patients received cilta-cel immediately after the BCMA targeted therapy. And these patients had received indeed the bispecifics and Belantamab maybe in the DREAM-1 or in the DREAM-2 study. So after a median of 6 or 7 prior lines of therapy. So now we have more information. Point number one, the patient to what you refer is going to receive cilta-cel maybe in a better situation, not in a so heavily pretreated situation. And you mentioned that the treatment-free interval between Belantamab and the CAR-T has been, I don't know how many years, but you pointed out approximately 2.5 years. So I think that this is going to be also important. And based on the real life studies, the longer the time between the two BCMA targeted therapy, the better the outcome. And in the real life studies, the cutoff has been usually 6 months, but I can imagine that if the treatment, the interval between the two BCMA targeted therapy is longer, more efficacy. So I would not have actually a major problem in order to go. And indeed, if you go, well, if you do bone marrow biopsy, it would be possible to check the presence of a BCMA just in order to be sure that the BCMA has not been lost.
Yeah, Marivy, and I think the other point I would make is that all of the sequencing data before and after CARs, the N is so small that I think
Sure.
we make definitive statements like you can't do this or you shouldn't do this. But the reality is the numbers are so small, the patients are so variable that I think it's hard to know. And I agree with you. Before I retreat with BCMA, we actually run a flow assay to see whether BCMA is still expressed. And you could argue if it's a mutation, then you may not pick that up. But if the flow antibody binds fairly well, I don't think there's a low chance that retreatment with a BCMA targeted agent is going to work. So I'm with you. I'm still, I don't think we have the answer.
Yeah, and what you said at the beginning is extremely important from the educational point of view. The information we have at the data are based on small series of patients. So we have to take care and we can give just the recommendations, but not solid data confirmed in well-designed clinical trials. I'm sorry, because I think that Saji, you were going to say something.
No, I was just saying that a lot of these data, not really the small numbers, but these are all the median, as you said, 6, 7, 8 lines of therapy. The future state patients are not going to be 7th or 8th line bispecific and CAR-T. We're looking at much earlier lines of therapy. So the entire kind of the spectrum of the profile of the patients are going to be different. It will be interesting to see, in a future state, if the majority of the patients, I don't know how many patients globally is going to get daratumumab or anti-CD38 as part of their upfront therapy. A lot of the times we are talking about, let's not use CAR-T in the first relapse, let's use it in the third line, because you have an option of its anti-CD38 based combination in the second line. Now, I think there'll be kind of a split in the future where a lot of patients are going to get the anti-CD38 in the front line, then the question is what you're going to use in the second line. And if the trials show that the bispecific combinations are really effective in that setting, then we get into the dilemma of, do we now put the bispecific in the second line and reduce the efficacy of CAR-T in the third line, or try and push the CAR-T into the second line and think about the bispecific in the third line? But globally, I think a vast majority of the patients won't get CD30 in the upfront, and the current paradigm will still hold true, that we can afford to wait for a little bit more for the bispecifics and the CAR-T.
Yes, sure. I think that this is the million question, and I don't have actually the answer. Well, I have my thoughts, and of course, if well, with the long-term follow-up, I think that the data from CAR-T4 are good in terms of efficacy, but also in terms of safety profile. And if the patient is young and the CAR-T is eligible, maybe this will be one important option, because if we expect a median PFS of approximately 50 months, I think that 50 months of a treatment-free interval is important for the patient. And we can sequence later on with GPRC5D bispecific monoclonal antibody, and even alone or in combination with daratumumab or with pomalidomide. And this sequence is optimal. But honestly, it is not going to be realistic for all patients, and especially the elderly population. In the elderly population is when I see the role for Bela-based combinations, and the great competition will be with the bispecific, because we don't have any data about bispecifics in early relapses. And I can imagine that they are going to be effective for sure, but what about the safety? And what about the infections and the continuous therapy? So,
The other thing we
safety
don't
piece.
factor in also is the fact that patients are going to get a much longer progression-free survival when we're using early on. So the gap between retreatment and treatment is going to be a lot longer. So all these data is probably that we have right now is probably not going to be valid at that point.
So I'm going to ask a provocative question, because I think the question is, there's a lot of questions about sequencing and what do you do where, and I see Herman on here. So I'm going to say it doesn't matter when you give your CAR-T, that the PFS is going to be the same. And so if that's the case, and you know that there's a treatment-free interval, why not do it later in the disease course when patients are sort of beat up from treatment, as opposed to earlier when they're likely progressing on maintenance therapy? But I did that to get Herman to answer something.
Good point. But I still believe that immunotherapy, the most effective immunotherapy, should be as early as possible. I think the fitness of the T cells, the immunogenicity of the tumor, and I still believe that with early immunotherapy, we might actually cure patients. So I would still go for CAR T cells first and try to. And what we also know is that with the bispecific, we get T cell exhaustion and we get more antigen loss when compared to CAR T cells. So I think this also, for me, is an argument to use CAR T cells earlier. But I see there are different opinions also.
So Mary, if you have a patient with rapidly progressive disease, what would be your your choice? A bispecific antibody or a Belantamab combination?
well, honestly, I don't know, Hanif. I think that whatever approach will be valid, because both are off-the-shelf drugs and they are going to be immediately available. We know, however, that a high tumor burden is a factor predicting less response with bispecific monoclonal antibodies because of the high levels of soluble BCMA. So it does depend, of course, on the efficacy we will see with bispecific monoclonal antibodies. But as both are off the shelf, I think that I will use whatever of bispecifics or Bela-based combinations.
I think more you were before me, actually.
Thank you. So before we can answer this question intelligently,
because progression-free survival is not always what comes up in our discussions with patients. The safety business is important in trying to really get a handle on what is non-relapse mortality in targeted immunotherapy. And I mean, I'm seeing stuff anywhere from 3 to 15%, and the fact that the non-relapse mortality is occurring as late as 36 months. And patients come in talking about, at least in the US or my practice, about going early to targeted immunotherapy. You start talking about a 5% non-relapse mortality, and they're completely shocked. They can't believe that people are dying from CAR T therapy. It's just not on their radar screen. It's not appearing in their chat groups. And when you try to get a sense of what is the non-relapse mortality with bispecifics and with CAR T, it's really all over the place, and it's really hard to even know what number to tell patients. And so, again, early death related to whatever, graft failure, infections, neurotoxicity, whatever you want to talk about, has to be incorporated into this dialogue.
Yes, sure.
I agree. I wanted to comment on home that from a biological point of view, I totally agree that you should move CAR T cells forward before the administration of bispecifics. But on the other hand, of course, we'll have to look at the toxicity, which may be less when you use your CAR T cells in earlier lines. We have indication that the late motor neurotoxicity might be less than using it in later lines. So that might be a pro for using CAR T cells earlier. That may also be the case for the second primary malignancies, maybe also being less when you administer the CAR T cells in earlier phase. But I do agree that we do need to know more about really the treatment-related mortality, especially now also moving to first line. And we know that the treatment-related mortality of autologous stem cell transplantation is very low at the moment.
Any other comment or suggestion?
I was going to direct to the notion that T cell exhaustion, and with ADC, even exhausted T cells within that platform, ADC would be effective, don't you think so? So Belantamab has a position after at the later stages, and so it will be a opportunity for patients. I mean, you are talking about Europe and US where you have access to CAR T, but there are countries like as mine, we don't have access to CAR T.
Yeah.
And we have only bispecifics for the time being. And so maybe we will have Belantamab. And so we will need to sequence between those two. And we will have very late advanced patients. That will always happen.
Yeah, no, I completely agree, and I think that this is one of the bullets I put in my summary slide, that the T cell exhaustion is not going to be a problem with the use of a Bela-based combination. So, of course, I think that the good news is will be to have BCMA ADCs based combinations in the market quite soon. I don't know why. And we will complement with the data from the bispecific monoclonal antibodies, and we will select what is the best approach for each patient.
I was just wanting to ask a sort of reverse question, in your opinion, about Belantamab and its value as we move down. We've talked about, trying to use the immunotherapies earlier. What do you feel about the value of Belantamab incrementally down the lines of therapy? I mean, I was really impressed with your data, that the fact it's being used early and we're seeing such powerful, and I'm less impressed when it's used later. Do you
Yes.
feel?
Yes, of course. And I think that this is in line with what Meral said. So at the end, we are going to have all possibilities, and with Bela-based combination, we need just to be sure that the target is present. And again, Sagar said, so it is possible to complicate and to evaluate the presence of mutations and so on, but just with flow cytometry, or in our case, we do bone marrow and by immunohistochemistry, we check the presence of a BCMA. And if it is present, well, you can proceed with the Bela-based combination because in principle, the T cell exhaustion is not going to be a problem. And the main mechanism of action is going to be driven by the release of the monomethyl auristatin F. So, of course, the ideal situation would be to use the earlier as possible because we are going to benefit to more patients, and maybe we know that the benefit is even higher when we earlier use this type of combinations. But I think that there will not be any problem in order to plan sequencing and to reserve for late lines of therapy.